Good morning. My name is Giovanni Marconi. I'm a researcher at University of Bologna and hematologist at Ospedale Santa Maria delle Croci in Ravenna. Today we are going to delve into the critical task of identifying acute leukemia in its early stages. Given the rarity of acute myeloid leukemia, a general practitioner may encounter only a handful of cases in his and or her entire career, typically between 5 to 15. Despite this infrequency, the aggressive nature of this blood and bone marrow cancer makes timely diagnosis paramount for effective treatment. In this video, we offer a concise guide tailored for general practitioners, focusing on the early detection of acute leukemias. Patients might come to you with symptoms that at first glance seem non-specific: a fatigue, fever, infections, easy brushing or bleeding, bone pain, confusion, headache, and swollen lymph nodes. The symptoms are often vague, making early suspicion key in primary care setting. Recognizing when to request blood test is crucial for diagnosis. Pay particular attention to severe or unexplained bleeding, persistent and unexplained infections, or pronounced shortness of breath. Those are red flags. In these cases, promptly ordering blood exams is critical. During your clinical assessment, be vigilant for signs of anemia, thrombocytopenia, and leukocytosis. A simple yet effective method to gauge anemia is to observe the vibrancy of the palm color of the inner eyelid. Also, be on the lookout for petechiae, small red or purple spots on the skin inside the mouth, indicative for bleeding. Enlargement of lymph nodes, peripheral edema, and shortness of breath could signal hyperleukocytosis. Don't forget to palpate for hepatosplenomegaly. Infiltrated gums may also be relevant signs of hyperleukocytosis in leukemia. Remember, it is the presence of a red flag or the ensemble of symptoms like fever and fatigue or signs of anemia, thrombocytopenia, and leukocytosis that could compel the execution of blood exams. This vigilance is particularly advocated when signs and symptoms have rapid onset. If you suspect acute leukemia in a patient, it is crucial to take immediate and comprehensive action. Start with ordering a complete blood count with differential and include in the lab evaluation liver and kidney function tests, uric acid, as well as coagulation study that contain fibrinogen levels. In situations where symptoms are particularly severe or in the patient exhibit one or more red flags, it is imperative that their blood tests are analyzed within a few hours. You must be rapid. If such rapid analysis isn't feasible at your setting, do not hesitate to refer the patient to the nearest hospital or emergency room. Emphasize the need for urgent tests when making the referral. Upon reviewing the results, prioritize evaluating the coagulation profile. A key indicator to watch for is low fibrinogen level, below 115 mg per deciliter, which, especially if accompanied by prolonged prothrombin time and partial thromboplastin time, may signal a particularly aggressive form of leukemia, known as acute promyelocytic leukemia. This variant requires immediate and intensive treatment. Next, examine the white blood cell counts, noting whether they are abnormal, high or low. Also, look for low hemoglobin and platelets level and assess the presence of blood cells. Pay close attention to any notes from the lab regarding the morphological evaluation of the blood smear. The morphology and presence of bloods are often reported under or near the leukocyte differential count. It is crucial to remember that leukemia can sometimes present with overt abnormalities in the white blood cell total number, hemoglobin, or platelet levels. Therefore, retain your clinical suspicion even if these values are normal or show only minimal deviation from the normal range. Additionally, close examine the white blood cell differential counts, particularly if there is an increase in monocyte percentage over 10% or a decrease in neutrophils percentage below 30%. Also takes note of the mean corpuscular volume of red blood cells. A value exceeding 100 femtoliters can be suggestive of hematological malignancy. When acute leukemia is suspected, it is imperative to refer the patient to an hematologist immediately. It is important to be aware that many hematology centers operate with specific referral protocols, often categorizing cases based on the urgency. As a general practitioner, familiarizing yourself with the referral process of your nearest hematology institution is pivotal. This includes knowing contact details like telephone numbers and email address, or understanding the procedure for direct referrals. In scenarios where a structured fast track referral system is not available, directing the patient to the emergency room can be the most expedient pathway to ensure they will receive the urgent care that they need. When referring a patient, the information you provide is key to a smooth transition. This should include a concise summary of significant blood test results, a brief description of the patient clinical condition, any red flag symptoms present, and notable ongoing clinical issues. This snapshot is vital for dermatologists to effectively pick up the case. Seamless communication between general practitioner and hematologist or a reference center is pivotal to ensure that every patient with a potential leukemia diagnosis receives the fastest and most effective care possible. Typically, a patient with a suspected case of acute leukemia will be evaluated by an hematologist within hours of the initial suspicion and blood test. The evaluation may be conducted in person or increasingly through telemedicine. The hematologist will then proceed with further essential tests such as bone marrow biopsies, cytogenetic analysis, and molecular testing. Remember, early diagnosis of acute leukemia can significantly impact on patient outcome. Be vigilant about the signs and conduct vigilant initial assessment and refer promptly. I would like to thank you, Alan, that supported this video.